Our next speaker is Peggy Walsh. She is a pharmacist and certified diabetes care and education specialist, serving 8 primary care practices within Ohio Health in the diabetes management program, along with dietitians, health coaches, and social workers, community health workers, and nurse care managers. During Peggy's almost 10 years at Ohio Health, she has focused her work on serving Ohio Health's major direct-to-employer wellness programs and corresponding populations of patients, along with Ohio Health Physician Group Diabetes Management Program. Prior to working with Ohio Health, Peggy practiced in the community, mail order, and inpatient pharmacy settings. Peggy has a Bachelor's of Science in Pharmacy from Novo Southeastern University and a Bachelor of Science in Microbiology from Florida Atlantic University. In addition, she is a certified diabetes care and education specialist, and she's been practicing pharmacy for almost 26 years. So let's together welcome Peggy.
So today I'm going to talk about how diabetes medications can affect weight. I have nothing to disclose related to the content of this presentation. And I have a few objectives that I'd like to accomplish today, beginning with a review of the different diabetes medications and how they lower blood sugar, discuss how different diabetes medications impact weight, and then provide some tactics to manage weight, potential weight gain with insulin use and other medications that cause insulin-like response. So the key organs in the blood sugar management we touched upon briefly before, but just to reiterate, we have our pancreas that releases insulin into the bloodstream when we have the high sugar. We have our liver that releases sugar into the bloodstream when things are going low. We have the kidney that plays a role by eliminating sugar from the body in urine. And then we have the muscles that will remove the sugar from the bloodstream to use for energy. So to begin with, we're going to talk about medications with the potential weight gain effect, starting with insulin, which is a hormone secreted by the pancreas into the blood to transport glucose into the cells to be used for energy. It acts through the receptors that are located on the membrane of the target cells, and we have a few major target cells. The liver, which promotes glucose storage, is glycogen. We have the skeletal muscle that stores glucose for short-term energy use, and then we have the fat cells that store glucose for long-term energy use. So this diagram kind of illustrates in a simplistic way how insulin works in our body. So if you think of insulin as a key, and it's going to unlock that channel to let the sugar in. So on the left side, insulin is a little purple triangle there is the key. It has its insulin receptor, and then on the other side is the glucose channel or door that's closed right now, and then we have the sugar floating around the bloodstream. So when everything works well, the insulin, the key, unlocks the channel and allows the red sugar balls to go inside the cell and be used properly. Sometimes that doesn't work, or it doesn't work well. And we talked a bit about that prior, but insulin resistance can develop. It's sometimes referred to as impaired insulin sensitivity. And basically, the key doesn't work anymore in the lock. So the sugar stays out in the blood. What happens is we build up an intolerance to the insulin becomes more ineffective, and then the pancreas keeps producing more and more insulin to try to manage the sugar in the bloodstream. So in this diagram, you can see we eat food, the pancreas makes the insulin, but now we have cells that are resistant to insulin, so the sugar stays out in the bloodstream, but it does get shunted into the fat and stored through other pathways other than the insulin pathway. The individual, though, feels tired, hungry, and just keeps repeating this process over and over. Another thing to take into consideration, too, is in our bodies, we always have balance and checks, right? So we call it homeostasis. So insulin cannot be left unchecked. If we did, we'd all have low sugar all the time. So we have stress hormones to kind of balance out insulin. We have the glucagon, which stimulates the liver to release the stored sugar. We have cortisol, which a lot of people I think are familiar with. That's released in response to stress. Usually, it can be physical or mental. And we call that the fight or flight response. It causes a rapid temporary increase in glucose production, and then it also increases insulin resistance in the cells. Epinephrine or adrenaline is actually the fight or flight hormone, and it's released in response to stress. It too signals the liver to produce glucose and increase that insulin resistance on the cells. And then the growth hormone, which also, as the name implies, is going to need energy, so to allow the body to do what it needs to do to maintain itself. So it increases glucose production and release from the liver and kidneys. So if you think of it in general terms, insulin's sole job is to get the sugar out of the bloodstream and store it. Our stress hormones on the other side, their sole job is to get the sugar out of storage and put it into the body so it can be used for the stressors. So we look at insulin and weight gain and the possible factors that might be related to potential. I say potential because not everybody that uses insulin gains weight. But the potential weight gain in type 2 diabetics using insulin. So on your left are the factors, and then on the right are the possible effects resulting from those factors. Number one, insulin storage effect. What does that mean? It means that now we're treating high sugar. So now we have insulin on board and actually doing its job. So it's going to be putting that sugar into storage. So it stimulates the muscle and fat glucose storage. Hypoglycemic or low sugar episodes. So sometimes when you're on insulin and you're still getting everything worked out, sometimes you might go a little low. And some people that's a little scary. And so to counteract that, they eat. And we call it defensive snacking. Especially if you have low sugar at night, then sometimes people will tend to have these large snacks before they go to bed. And it's just a barrier. I've worked with patients and it takes a little time, but a lot of times we can get through that. But excess calories are going to be put into storage. So that's another factor for weight gain. Relying on insulin to treat your sugar without improving your diet. So that leads to a false sense of freedom to eat anything you want. Genetics, some people have greater abdominal weight gain. Some people have more elevated cholesterols and fats. Correction of excess glucose in the urine. So if people are untreated with high sugar, the kidneys are kicking in. They're trying to push out the sugar. Once we get you treated with the insulin, if that's the medication we're using, then we stop that process so that sugar that's been urinated out is now available for storage. And then the catch-up process. Some people lose weight when they have untreated diabetes. Once we treat your diabetes, regulate your sugar levels, then most of those people will regain that lost weight at that time. So, how do we limit insulin-related weight gain? As we just heard, calories in equals calories out. But I like to think of it, calorie is a unit of measure of energy. Glucose or sugar is energy. So if we can get balance of what we're taking in and what the body's burning, we're not going to gain or lose. If we take in more than our body can burn, we're going to have weight gain. If we take in less, then we're going to have weight loss. So that being said, weight management may be the most important therapeutic intervention for obese type 2 diabetics. And basically it just stops that vicious cycle of that progressive pancreas dysfunction and insulin resistance, which leads to higher insulin doses and more weight gain. And then secondly, exercise. And it can dramatically decrease insulin resistance. That's huge. It makes the body more sensitive to insulin. And then as you're exercising, building more muscle, then we have more muscle to pick up and take out that sugar from the bloodstream. And it's a win-win situation. So now that we've talked about insulin, The next several medications are oral medications. They're used to treat diabetes, and they're similar to insulin in how they work. Sulfonylureas, glimepiride, glipizide, glyburide. They're the oldest ones that we've been using since the 1950s. And their sole mechanism of action, or the way they work, is to have the pancreas push out insulin if it's capable. It also helps reduce the glucose output from the liver. They're generally taken once or twice a day shortly before a meal. Potential side effects could be the low sugar and the weight gain, because they're acting for insulin, if you think of it that way. The second group is the meglitinides, repaglinide and nataglinide. And if you haven't heard of them, it's because we really don't use them very often. But they followed the sulfonylurea class. They do the same thing. They stimulate the pancreas to release insulin. But the difference between them and the sulfonylureas is they're very rapid acting. So they do have to be taken before each meal, about 30 minutes. And then you have to make sure that your meal has carbohydrates in it, because otherwise that potential side effect of low blood sugar, you're going to drop low quickly. So that's why they kind of fell out of favor, because most people can't be that. It's difficult to have that type of meal plan throughout the day. They also, too, lead to weight gain. And then lastly, in the weight gain class is the TZDs, Actose or pioglitazone. And they work differently. They work on insulin sensitivity in the muscle and fat cells, and they, too, reduce the glucose production in the liver. So the benefit with this class is that it can lower the blood sugar without causing the hypoglycemia. Now, they have been found to worsen or increase the risk of heart failure in some people. They can cause fluid or edema in the legs and the feet. There's an increased risk, more so in females and males, for bone fractures. And there is an increased risk for bladder cancer in some people. So the weight gain is going to be due to that increased insulin sensitivity, allowing insulin to get the glucose into the fat cells for storage, and also that water weight from edema if you're one of those individuals that has that side effect. So the next group are our neutral weight medications, beginning with metformin, which is still considered the first line medicine for type 2 diabetics. And the way metformin works, it just quiets the liver down, so it's not releasing all this sugar, especially during periods of fasting, which would be in most people sleeping, and then if you have long periods of time in between your meals. It also increases insulin sensitivity in the muscle cells so that we can use our glucose for energy. It's usually taken once or twice a day. And the side effects are usually, you always hear this a lot, the nausea, stomach upset maybe sometimes, or diarrhea. And we can usually treat that with changing, if you're on an immediate release formulation, move you to an extended release formulation, and then taking it with food. But not everybody can tolerate it. There are some rare side effects, lactic acidosis, which is usually found in really high doses, and vitamin B12 deficiency, but you should be having these checked every year or two. It's available generically, which is great. But also it's found in a lot of combination drugs with other diabetes medicines. Some are generic and some are brand. Our next, I'm sorry, I forgot about this slide. So this is just a diagram of basically summarizing the different areas that metformin works: the liver, the fat cell, the muscle cells. And then our next group, Januvia, Tradjenta, Onglyza, Nesina, DPP4 inhibitors. And they're considered weight neutral. So as the name implies, they're blocking the enzyme DPP4, which prevents the breakdown of the gut hormones GLP-1 and GIP. So in this diagram, you can see the drug in the blue box blocking the yellow enzyme, which allows GLP-1 and GIP levels to stay higher and have more of a benefit to the body. And the benefits are it decreases glucose output from the liver again, helps the pancreas make more insulin, stops glucagon release from the pancreas, because remember, glucagon opposes insulin, and then increases insulin sensitivity in the fat and muscle cells. It's taken once a day with or without food. It doesn't cause weight gain. It's generally well tolerated. Potential side effects are kind of go along the line of where it works. So sometimes people will have stomach upset or diarrhea. It's not very common to have that though. And then rare side effects, pancreatitis and joint pain. So now we're going to move into the last group, which is our medications with potential weight loss effect, beginning with the new kids on the block. GLP-1 and dual GLP-1 GIP receptor agonists. So here's a list. It's not all-inclusive, but I think I've covered pretty much everything that's on the market. There is one oral available, which is Rybelsus, which is the generic name semaglutide. And then we have our injectables. So Ozempic, and I'm not singing the jingle. We have, that's once a week. Trulicity is once a week. Bydureon's once a week. Victoza is slightly older. That's a daily injection. And then we have Mounjaro, which is the only dual GLP-1 GIP receptor agonist on the market right now. There's lots in the pipeline coming up. And then you'll notice Ozempic, Trulicity, and Victoza have a little star after them. And that's because studies have been showing that they're providing cardiovascular benefits. So the GLP-1 and GIP receptor agonists are very similar to our natural occurring ones, but they're made to be resistant to that DPP-4 enzyme, so they're not going to break down. So we can build up levels over time, still get the same benefits that the DPP-4 group provides, that's highlighted in red, but then also this group decreases appetite via the hunger center in the brain. So I think it was said the tank is full. I like that. And then it slows down digestion, that whole process, and stomach emptying. So that too creates that sense of fullness. And those two alone are what promote that weight loss. As I said, the studies are out now that there is cardiovascular benefits with these medicines, but also they're showing that they slow the progression of kidney disease in some people. So this diagram shows you our GLP-1 is affecting the brain, decreasing our appetite. It's slowing down the stomach emptying. In the pancreas, it's increasing insulin secretion, decreasing that glucagon secretion. It's increasing the biosynthesis of insulin, which is the production of insulin. It's increasing more beta cells, which are the cells responsible in the pancreas for making insulin. It's increasing insulin sensitivity in the fat and muscle tissues. It's decreasing the glucose production in the liver, and then we have the heart with improving function and providing cardioprotection. So those cardiovascular benefits that I mentioned, what they're finding is we're getting decreases in non-fatal heart attacks, non-fatal strokes, and overall cardiovascular death, which improves our cardiovascular outcomes. All of that being said, they're not for everybody, okay? So people with triglycerides over 500, they're not for people with a history of certain thyroid cancers, folks that have diabetic retinopathy, people that have like irritable bowel syndrome with a focus on constipation, a history of pancreatitis, if they already have what we call diabetic gastroparesis, which is a slowdown of the digestion tract to begin with, if you're pregnant or breastfeeding. The potential side effects are really, again, where is it working? So we're talking about nausea, vomiting, sometimes pain in the GI area, but that's more common when you first start the medicine or if you're going to be increasing the dose. Generally, You start low, go slow. So that means we start at the lowest dose possible, keep you on it for 4 weeks. If we still need to increase because your sugar numbers aren't there, then we go ahead and we step you up a little bit, another 4 weeks, and we just progressively move up. However, you can sometimes have these side effects in the middle of your treatment too if you consume larger quantities of food that your stomach can't handle anymore because we've slowed down the process of digestion. Also, if you consume high fatty foods or foods that are high in carbohydrates, that can cause GI side effects as well. Usually when I talk to patients and that's going on and we look at what they're eating and then they make some corrections, when I talk to them next, they tell me that they're tolerating the medicine. So the rare side effects, pancreatitis, bowel obstruction, and the actual gastroparesis. So our second group of weight loss potential medications are the SGLT2 inhibitors, Farxiga, Jardiance, Stelgatro, Invokana, Brenzavvy, and those with the asterisk behind their names, Farxiga, Jardiance, and Invokana have found to reduce cardiovascular death and heart failure and slow chronic kidney disease. As the name implies, they block or inhibit the SGLT2 protein that's found in the kidneys. This causes, by blocking this causes the sugar to be removed from the body through the urine rather than being recycled back into the blood. So the benefit with this category of medications, it improves the blood glucose levels. There is a modest weight loss. There's small decreases in blood pressure in some people, and they find that it is providing renal protection. It is known to help improve outcomes in people with heart and kidney disease, as well as heart failure. And what's really interesting and exciting is it's also being used now in people that don't have diabetes, that have chronic kidney disease and heart failure. So the potential side effects are going to lie where this works. So the urinary tract. If you're prone to genital yeast infections or UTIs, this is not a medication that's appropriate for you. So if we're putting all this sugar out through the urine and you're not staying properly hydrated, then this becomes a perfect breeding ground for yeast and bacteria. So we need to stay hydrated while we're on this. There is more frequent urination with these, but that's also from the nature of it. Where sugar goes, water follows. So we want to make sure that we're just constantly keeping up with our fluid intake. Not that you have to drink gallons, but you just have to be aware. And then it can cause low blood pressure in some people just because we're dropping the fluid in the body when we're urinating. All of that being said, with the hydration being the most important thing, we want to make sure if you're sick, so if you're nausea, vomiting though, and diarrhea, your fluid intake isn't what it's normally, hold the medicine. Wait till you're feeling better, and once you're drinking again and eating normally, then you restart it. Likewise, if you're going to have a surgical procedure, it's recommended to stop that 3 to 4 days or whatever your surgeon says prior to the event, and then you can restart it once you return to your normal hydration. And then this diagram just illustrates where these medicines work. So typically we have the kidneys are there to filter and clean the blood. Well, normally we would reabsorb that sugar back into the body, but these medications stop that process so the sugar just flows out through the urine. Our final group are the alpha-glucosidase inhibitors, acarbose and maglitol. And you may not be familiar with them either because we don't use them that much because of their side effects. But so these medications block another intestinal enzyme, alpha-glucosidase, which is normally used to break down starches into sugar. When these first came out, we called them the starch blockers. And It slows down the digestion of the carbohydrates in the upper part of the small intestine, and so that helps to reduce those sugar spikes after a meal. They're taken with the first bite of each meal, so you have to take them more frequently, and they promote weight loss by increasing that GLP-1 level we talked about, and so we're slowing digestion, we're decreasing appetite, and we're promoting that sense of fullness. And this is why we don't use them very often, because the side effects, gas, stomachache, diarrhea, bloating, come from the fact that now we're digesting further down in the small intestine where the bacteria are. And the bacteria byproduct is gas, and then it can cause diarrhea. So the side effects are fairly common and not very agreeable with most people. So they're not used much. And also people that have any kind of GI condition should not be using these either. And this diagram just illustrates. On the left, without the medication, you can see the absorption of carbohydrates is very concentrated in the upper small intestine. When we take the medication, now it's a little more evenly distributed, especially in the lower small intestine, whereas on the left there was no absorption, and now on the right we have some absorption. So to just summarize again, bring everything back together, we have the three potential effects on weight. So weight gain effect, that group's going to be insulin, and then medications that mimic insulin. So we have sulfonylureas, meglitinides, and the TZD group. Weight neutral, metformin and DPP-4 inhibitors. And then our weight loss group, the GLP-1 and GIP receptor agonists, our SGLT2 inhibitors, and alpha glucidase inhibitors. But thank you. I appreciate your attention today.